Good afternoon and welcome to our webinar. What is chemotherapy and how does it work? So in this webinar, we will look at what chemotherapy is, what it does and how it works. We'll cover why it's used for lymphoma treatment, how it's given and why it's given in the regimes that it's given in. We'll also cover some of the issues around late effects and balancing the risks and the benefits to individuals. And I am delighted this afternoon to be joined by two incredible speakers, Professor Graham Collins, a consultant haematology at the Oxford University's hospitals, and Ruth Jackson, a haematology nurse clinician from St Helens and Knowsley Teaching Hospitals. Welcome both and thank you for joining us this afternoon. So we're going to ask Graham to make his presentation and then Ruth to make her presentation. And then if there is time at the end, we'll do some questions and answers. So without further ado, I'll hand over to Graham.
Thank you very much, Dallas, and thank you for Lymphoma Action for asking me to do this and for everybody for joining. So I'm going to talk about the what, the why and the wherefore of chemotherapy. Some of it will get a little bit technical, I hope not too technical, but I do want to give you a real taster of what chemotherapy is, why we use it, and particularly why we use it in the way we do. So first of all, the basic question, what is chemotherapy? Well, all the name means is treatment with drugs, chemo, chemicals, therapy, treatment. So it really just means treatment with chemicals. And it could apply to anything. It could apply to infections, it could apply to autoimmune diseases, but we generally use the term chemotherapy when we're talking about treating cancer with drugs. Actually, the term initially was used for infections. It was used for antibiotics, but nowadays, most of us when we use the term chemo or chemotherapy, we mean treatment of cancer with drugs. Also, we often talk about targeted therapy differently from chemotherapy. So targeted therapy is where drugs are designed to interrupt a particular aspect of the biology of a cancer cell. And that's generally not what people mean when they mean chemotherapy. Chemotherapy is a bit more, can I use the term blunderbuss, a little bit more non-specific in its action. Still can be very good, but is a bit more non-targeted. It's also different from what people often call immunotherapy. Immunotherapy is when drugs are used that primarily target the immune system, not the cancer cell. And the idea is it peps the immune system up so that it can go and fight the cancer. Chemotherapy is generally drugs used that directly target the cancer. Often it's called cytotoxic, which means toxic to cells. So it's drugs that are toxic to cancer cells, basically. So how does chemotherapy work? Well, chemotherapy generally relies on the fact that cancer cells divide. Now, not many cells in our body, in the adult, are dividing at any one time. The cells in our bone marrow are dividing, the cells in our hair follicles are dividing to make cells, and the cells on our lining of our gut are dividing because they have to, because they get shed off as the sort of food goes down as it's digested. But not many of the cells in our body are dividing at any one time. But cancer cells do generally divide more so than most normal cells. And when a cell divides, you start off with a mother cell here on the left. The first thing that happens is that the DNA replicates, so it literally duplicates, you get two copies of it. You then get something called a mitotic spindle, which is this white sort of structure, looks a bit like a spider web, and that's really important for how some chemotherapy works. That spindle then literally sort of rips apart the two copies of the DNA into opposite sides of the cell, and the cell then pinches off and you end up with two daughter cells, both with the same DNA as was originally in the mother cell. Now this is called the cell cycle or cell division, and some chemotherapy drugs target cells at very particular times of this cell cycle, and other chemotherapy drugs can target cells at any point in the cell cycle. And one principle of combination chemotherapy, so using multiple drugs at the same time, which we'll come on to a bit later, is to use drugs that target different parts of the cell cycle, so that you get around any potential resistance that cancer cells may accumulate. So how does chemotherapy target cancer cells specifically? Well, as I've sort of alluded to, cell division in cancer cells is unregulated. It's not always quick, I mean it is in some cancers, but it is unregulated. It doesn't happen in a regulated fashion. So chemotherapy that targets parts of this cell division process will usually kill cancer cells preferentially to normal cells, particularly ones that aren't dividing very much. However, the cells that are dividing, so the lining of the gut, the hair follicles, the bone marrow, they are affected by chemotherapy, and that's why Chemotherapy causes nausea and sometimes diarrhea because it affects the cells of the lining of the gut. It's why some chemotherapy, not all, but some chemotherapy can make your hair fall out. And it's also why most chemotherapy drugs can suppress the bone marrow and lead to an increased risk of infection because the normal white cells aren't produced properly. So that's one reason why chemotherapy targets cancer cells. Another reason is that cancer cells are not always very good at repairing DNA. So many of the many chemotherapy drugs work by damaging DNA, and cells actually have processes that can recognize that damage and repair it. And normal cells are pretty good at doing that under normal circumstances. But actually, cancer cells are a bit less good at repairing DNA. They're quite sort of sick cells. So actually, causing a little bit of damage to DNA in cancer cells may kill a cancer cell, whereas it wouldn't necessarily kill a normal cell. And I should say from the outset that most lymphomas are very, very sensitive to chemotherapy. There's various reasons for that, which I won't necessarily go into, but lymphoma is one of the more treatable cancers with chemotherapy. Certainly, chemotherapy is more effective than in many other types of cancer that you might come across. So what drugs do we use for chemotherapy? Now, this is where it might seem a little bit technical. I hope it won't be too difficult. But basically, there are lots of different types of chemotherapy. I guess that's one thing to say. And that's really important when, I'm talking about chemotherapy with a patient in clinic. Often they'll say, oh, yes, I had a friend who went through chemotherapy and it was awful, and it might have been awful, but actually it was probably very different chemotherapy from that I'm going to be discussing with the patient. So it's important not always to use other people's chemotherapy sort of experience to colour your own possible journey. It may be completely different drugs that they're having. Even if it's the same drugs, different people respond very differently sometimes in terms of how they tolerate very similar chemotherapy. So I've listed some of the groups of chemotherapy drugs here. So if we start on the top right, there are these drugs called alkylating agents. Now, what they do is they add a chemical group called an alkyl group to DNA, and they stop the DNA functioning. You need DNA to act as the blueprint of the cell, and if you've got chemical groups stuck on it, then it doesn't really work in that sense. And these are very effective drugs. There's one example is cyclophosphamide, which is a very commonly used chemotherapy drug in lymphoma, and another is bendamustine, which is often used in low-grade B-cell non-Hodgkin lymphoma. On the top left, we've got antifolate drugs. Now, folate is the same as folic acid. You may have come across folic acid. It's a common vitamin. You may well be taking it in the breakfast as part of your breakfast multivitamin. And folic acid is needed to make DNA. So if you have an antifolate drug that sort of acts against the action of folic acid, it stops the synthesis of DNA. So that process of DNA replication that I showed in the previous slide is interfered with, and then a cell just can't divide properly and it dies. And probably the most famous example of this is methotrexate, which is used for some types of high-grade and indeed low-grade non-Hodgkin lymphomas. Bottom left, nucleoside analogues. Well, nucleosides are the building blocks of DNA. So you need nucleosides to grow a DNA chain during replication. And nucleoside analogues mimic those building blocks. They fool the cell into incorporating it into a growing DNA chain. But when it stops that chain growing any further. And that means it can't sort of carry on and successfully replicate the DNA. And there are drugs such as cytarabine and fludarabine, both of which are used in various contexts in a number of different blood cancers, actually, which are nucleoside analogues. And then the bottom right are the vinca alkaloids. Now, they hold a special place in lymphoma actions heart because they come from the vinca plant, and the vinca plant is the lymphoma action logo. Many of you might have it in your garden, the vinca plant. And vinca alkaloids, they interfere with the cell when it's dividing. Remember I said that you have that sort of almost like spider's web spindle which rips the two strands of the DNA apart so the cell can divide. Well, it interferes with the formation of that spindle. So it's a very specific sort of target, and the best example there is vincristine, but there's also something called vinblastine. And if you have a patient with difficult Hodgkin lymphoma or T-cell lymphoma, we might use brentuximab vedotin, which is an antibody treatment, but it's got a chemo drug on the end of it, and that chemo drug on the end of it is a potent spindle poison, as we call them. So there are many different types, and they work differently within each sort of class of drugs. So why do we combine chemo drugs? We often don't use them as a single agent, we often use them in combination. And really we learned how to do this many years ago from our infectious disease colleagues. And it was largely people being treated with TB, actually, that taught us a lesson in cancer medicine. And what they realized from treating, let's use TB as an example, is in TB, you can use a single antibiotic, and most of the bacteria in TB will be sensitive to that antibiotic, but one or two may be resistant. So that's what you see on the bottom left here. All these gray bugs are sensitive to the single antibiotic, but the red bug is resistant. So when you start taking those pills, the gray cells start disappearing because they're sensitive, but it doesn't affect the red cells, the red bacteria. They grow. And in fact, as they grow, you may develop a different type of resistance. Those are the yellow bugs. So although you're treating the gray bugs very successfully, you're not getting rid of the infection because you've developed a resistance to that antibiotic. And exactly the same thing happens in cancer. If you treat with just one chemotherapy drug, you may well kill most of it, but actually there may be some cells that are resistant to it, and they are selected, positively selected. That's the phrase we often use, in that they start growing selectively because we've killed off all the ones that are sensitive, and that leaves space really for the ones that aren't sensitive to the chemo drug to grow. Whereas if we use multiple antibiotics in infections or chemotherapy drugs in cancer, we can get around that resistance developing and kill all of the bacteria or all of the cancer cells in the first go. So that's why for TB treatment, you take multiple antibiotics, which you do, and it's why for cancer treatment, we often give, particularly when we're trying to cure cancer, we often give combination chemotherapy drugs, not just one. So I want to give an example of a combination chemotherapy regime. Probably the best known one in lymphoma treatment is R-CHOP. This is the commonest regime we will give to patients with lymphoma. I often say to my trainees, if anyone asks you how to treat a particular type of lymphoma, if you say R-CHOP, you're probably right. And it's a combination of drugs. It's 5 drugs, and it's an acronym. So each of those letters stands for a different drug. I've listed the drugs on the left-hand side of this table, and you might think, hang on a sec, okay, R rituximab, C cyclophosphamide, doxorubicin doesn't start with an H though. Well, that's because hydroxydornarubicin is another term for it. We don't use that term, but it's another term for it. And vincristine doesn't begin with an O, but it used to be called oncovin, which is where the O comes from, and then P for prednisolone. So that's the sort of combination of drugs. And I won't go into the details, but I just want to make the point that the action of each, the mechanism of action of each drug differs. And that's the important point, is the differing mechanism of action. And that gets around resistance mechanisms. They work on different parts of the cell cycle. And that's important because if we were targeting only cancer cells in one part of the cell cycle, we would miss other cancer cells that are in other parts of the cell cycle, and that's no good. So we need to use drugs that work in different parts of the cell cycle. And also we need to use drugs that have different side effects. If we used 5 drugs that all cause nerve damage, well, you'd have terribly damaged nerves by the end of it. One of the drugs can damage nerves, that's the vincristine, but the others don't. So we can use them safely in combination. There is some overlap in toxicity. The cyclophosphamide and the doxorubicin, as you can see, both suppress the bone marrow and increase risk of infection. But overall, there are a lot of non-overlapping side effects, and that's really important when picking a combination. Rituximab, by the way, it's not really chemo. I guess you could regard it as immunotherapy. It's an antibody, but it does target cancer cells directly. So in that sense, it is still a chemo. So the next question is, why do we give multiple cycles? You know, if you're getting R-CHOP, often we give 6 cycles, given once every 3 weeks. Well, why do we give it like that? Why don't we just give one lot and be done with it? Well, that's this concept of fractional kill. And I've tried to illustrate this on the right in a graph. I don't know what you like with graphs. I quite like graphs, but you need to sort of pause a little bit and understand them. So on the y-axis there is number of cancer cells. And let's say you've got lymphoma and it's untreated. You might have something like 10 to the power 11. So that's 1 with 11 zeros on number of lymphoma cells in your body. That is a lot of cells. And when you give one lot of chemo, let's say your first cycle of R-CHOP, that kills a lot of the cells, let's say 99%, but you're still left with 10 to the power, whatever that is, 9 cells. That's still a lot of cells in the body, even though it's a lot less. So you might notice a lump shrink right down, but actually there's still going to be a lot of cancer cells there. The next cycle kills the same fraction, let's say another 99%, but you're still left with cancer cells there, so you haven't cured it. And so you have to give multiple cycles. And if you sort of do the maths, if you kill 99% each time and you start with 10 to the power 11 cells, you need 6 lots of chemo so that you've got less than 1 cell remaining. In other words, you've cured the patient. Now, obviously, maths never works out that easily in patients, but that's the principle. It's a fractional kill. What you might notice from the graph as well is that as you wait between cycles, you might get some regrowth of the cancer of the lymphoma. And obviously you don't want that. And you might say, well, why do we wait between cycles? Well, we wait between cycles to let the body recover. We can't just give continuous chemotherapy. It's too toxic to the body. It won't tolerate it. So we do have to give most sort of conventional cytotoxic chemo in these cycles to allow your body to recover. But thankfully, your body usually recovers faster than the cancer cell. Remember, cancer cells are quite thick cells, so they often recover less well than the healthy bit of the body does. And that's, again, handy because it means that usually we can give chemotherapy frequently enough to kill the cancer, but not frequently enough to do serious damage, at least to the body. How do we work out the dose of chemotherapy? Well, really, this is worked out in clinical trials. When there's a new drug, whether it's chemotherapy or targeted therapy or immunotherapy, we enroll patients onto a clinical trial that's aimed at finding the right dose of the drug. So it often starts at very low doses, which we know won't work very well, and we're very open with the patients who enroll into the trials about that, but we know it's safe. And then as more patients are enrolled, they get higher and higher doses. We can work out how well that drug's working, but also what the side effects are, and is it tolerable? So once we've got a drug with a dose that's tolerable and that is working, well, that's the dose that's taken forward generally. Now, patients are different, so we don't use the same dose of drug for each patient, but we work out the dose per patient by the patient's height and weight, and that gives the body's surface area, and it's usually the surface area of the body how most drugs are dosed. And the surface area is meters squared, and a typical adult would be about 2 meters squared, but it does vary depending on your height and weight, and that's how we work out the exact dose to give. There are other factors, though, that make us fiddle around with the dose. So most chemotherapy drugs are excreted from the body by your kidneys or your liver, and if your kidneys or your liver aren't working properly, you may need to reduce the dose of the drug so that it doesn't accumulate too much and cause too much damage. You also might be taking, a patient may be taking drugs that interact with chemotherapy drugs, and we may need to adjust dosing based on that. And the patient also may have specific medical conditions that make a particular chemotherapy drug more risky. For example, if a patient has a heart condition, we're going to be very careful using a drug called doxorubicin, because that can also damage the heart. So that may affect the dose we use. It may even mean we don't use that drug because it's just not safe. And for every chemotherapy protocol, such as R-CHOP, every chemotherapy regime rather, such as R-CHOP, there's a protocol which is, several pages of what we do, how we dose, how we adjust those doses in different circumstances, who it's safe to give it to, who it's not. And an important part of our job is following those protocols to make sure the chemotherapy is given safely, appropriately. Why do we use different regimes? There's, I don't know how many regimes there are, but there must be about 150 different chemotherapy regimes for lymphoma, at least, I thought. Well, when we see a patient in front of us and we're recommending treatment approaches, we go through a number of questions. One is, why are we giving the chemo? What's the purpose? Are we trying to cure the lymphoma? And we can do that with Hodgkin lymphoma. We can do that with high-grade non-Hodgkin lymphoma. But we can't do it, unfortunately, with low-grade lymphoma with standard chemo. So if we're aiming for cure, obviously after discussing it with the patient, but we can potentially justify a slightly more aggressive approach with slightly more side effects if we're trying to cure it. Whereas if we know we're not going to cure it, well, our aim really is quality of life and a good long remission. But in that case, we want to be a little bit more careful with the drugs and the doses that we use. So, that's one consideration. What's our aim? The second, I've already mentioned actually, is does the patient have medical issues that preclude certain types of chemo, in which case we would use different chemo. And also a key consideration is what the patient wants. And hopefully, if you see a doctor and they're talking to you about the treatment, they may well give you a number of options, and taking the patient's views into account is an important part. Now, in some situations, there is one obvious regime that the doctor will say that I would strongly recommend that one. But in other situations, it is a bit more nuanced. So I've got an example here. So imagine a patient with follicular lymphoma, that's a low-grade non-Hodgkin lymphoma, never treated before, but they do need treatment because they've got lymph nodes causing discomfort. Well, there are three main options that I would talk through a patient with. There are actually other options, but these are the three main ones. The chemo on the left is bendamustine. Now, rituximab and bendamustine is very effective. You often get 10-year remission. It's generally kind on the heart and kind on the nerves. Your hair doesn't fall out, but has a slightly higher risk of infection. And in older patients, it really can be quite toxic. In fact, it may, there's an appreciable chance of a patient dying of infection in bendamustine as they get older. So, there are some pros and cons. R-CHOP, I've already mentioned, again, very effective, average 10-year remission. If as a doctor I'm worried the patient may have an element of high-grade lymphoma as well as low-grade, then that really is the optimum choice. But it can damage the heart, it can damage nerves, and it has steroids in it, which, particularly if you're diabetic, can cause issues. RCVP is another option. It's not quite as effective as the others, maybe 6 to 8 year remissions. It's very well tolerated. So we used to be told you can give R-CHOP to your mother and RCVP to your grandmother. That's obviously slightly broad brushstroke, but it is very well tolerated. It's very kind on the heart. Hair doesn't usually fall out, but it can cause some nerve damage. And again, it still has steroids. So you can see there's pros and cons of each, and the patient may have various factors that help determine which is best. Why are some drugs left out of a regime? You know, some chemotherapy drugs can be left out at the beginning if it's not safe to give it. So I've mentioned the doxorubicin and heart trouble. We may actually swap a different drug into R-CHOP, take the H out and put a drug called gemcitabine in. So we may do that if the heart's an issue. And there's another drug called bleomycin, which we use in the Hodgkin lymphoma, which is quite well known to damage the lungs. It's pretty rare actually, but it can happen and it can be serious. And it's more common as people get older or in those with underlying heart disease. So we may leave it out in its entirety in those patients. But there's also been a clinical trial done showing that if you have 2 cycles of ABVD, you're in an excellent remission on a PET scan. You need another 4 cycles. You can actually leave the bleomycin, the B drug out, and that doesn't reduce the cure rate, but it does make it safer. So there are sometimes we have clinical trials to guide us on that. What about the late side effects? This is obviously a concern of people who've had chemotherapy. Well, I think it's important to say most patients get back to a normal quality of life after chemo, often with very few later effects, but some patients do struggle with later effects. Some are predictable. So I've mentioned doxorubicin, that does increase the risk of heart disease later in life. That is a predictable side effect, but it's only a small risk, so most patients won't be troubled by it. Vincristine, this vinca alkaloid, can damage the nerves, which can give you pins and needles or numbness in the fingers and toes. It usually improves after treatment, but sometimes not completely. And there are also stronger regimes, such as one we sometimes use in Hodgkin called escalated BCOP, that can reduce fertility. It can sometimes bring forward the menopause in women. So that's potentially important later effects. Some are much less predictable. Fatigue, fatigue can be a really troublesome side effect, and it can be long lasting, but it's so difficult to predict who is going to have an issue with fatigue and who isn't. And also joint pains can be quite common post chemo. I don't really understand why, and it's extremely unpredictable. So it can be challenging to know how drugs are going to affect patients in the longer term. So I think that's all I was going to address. I will now pass over back to Dallas. Thanks, Dallas.
Thank you so much, Graham. That was absolutely fascinating. Thank you. And we've got some extra questions coming through, which hopefully we'll get to at the end of the session. But I'm now going to hand over to Ruth Jackson for her presentation. Thank you, Ruth.
Thank you very much. Thanks to Lymphoma Action for asking me to speak today. I've been involved with chemotherapy as a nurse for 23 years now in various job roles. Quite a few years ago now, I was a chemotherapy nurse. I've been a haematology nurse specialist, and currently I'm a nurse clinician within the haematology service. I work in a hospital just outside of Liverpool. I work across 2 hospital sites, so keep very, very busy. So what I'd like to talk today about is just sort of building on what Graham said, actually, is just mainly the practicalities, about where we give chemotherapy, what to expect, different routes and modes of administration. We've already mentioned some of the side effects, but I'll just build on those a little bit more, and in particular some of the late effects that we look out for. Who you might go to if you need help during chemotherapy. It can be quite a daunting time, if you know that, especially if you've had a period where you've been on a watch and wait protocol, you've not needed any treatment for your lymphoma for many years, only to be now faced with the prospect of needing chemotherapy. So it's worth to get help and advice from during and after treatment as well, because that can be equally as daunting as well. A little bit of what I'll talk about is sort of in my practice at my hospital, but I'm sure there are various models of this around the country. So when we know that a patient needs to embark on chemotherapy, often the patient's already met with a consultant in clinic. And I think at that point, you know, for some lymphomas, that can be at the point of diagnosis. You know, there may not have been a period of watch and wait. So you go from being told you've got a cancer to actually you need to start chemotherapy quite quickly. So we were finding that that clinic appointment was not the best arena to be to give him more information about the chemotherapy on what to expect really. So we've set up a pre-chemotherapy assessment appointment with our specialist nurses. It's a bit like if you were going for an operation, we all know that we need to attend a pre-op, and there's a little bit of work to be done when we go to a pre-op. We need to have blood tests, and you know, we get told a little bit more information about what the surgery might entail. Well, this is the same for chemotherapy. So we have a pre-chemotherapy assessment, and at that appointment we also undertake the written consent. We like to conduct holistic needs assessment. So that's, you know, not just assessing our patients physically, but also emotionally, thinking of what social problems they might encounter. You know, I've got patients who live alone, you know, relatives live many hundreds of miles away. So actually, what can we put in place to support them before chemotherapy commences? Another important consideration is fertility preservation. I meet a lot of young patients who've not yet considered starting a family, and this could be a really important decision. You know, as we've already discussed, not all chemotherapies might have a negative impact on fertility, but we do, where possible, like to send, we give our patients the options, you know, if they've not yet considered family planning, to consider sperm banking. We have very good links with the Liverpool Women's Hospital. They're one of our local fertility centres. So if we have got a patient who needs to be sperm banked, we telephone them the same day, we send over a referral, and the patient's seen in their clinic the next day. It's really that quick. It's been a little bit more logistically difficult for our female patients when we're thinking of egg harvesting and preservation, but actually, again, we've got really good links with our fertility centre, and these are conversations, and you know, we're still sending our female patients as well for consideration of fertility preservation. So I'd really encourage any patients out there to discuss these with their health professionals. We also, before chemotherapy commences, we think about our teenage and young adult patients. So I treat patients from the age of 18 years upwards. It used to be 16. Our centre now only takes from 18. And it's what we do is any patients that are between 18 and 24, we refer them to our teenage and young adults MDT, to the multidisciplinary team meeting there. And this just makes sure that they have some extra support. We also give them the option to be treated in a teenage and young adult centre, as that might be more age appropriate. But you know, I meet some patients who are 23 and 24, and actually they're married with 2 children, so they absolutely don't want to be having their treatment with patients that are 16 and 17. So I think it's really important that we give those choices. Likewise, I've met some 23-year-olds who are perhaps a little bit immature, and they would prefer to be around younger patients rather than older patients. So these are all the things that we think about even before the chemotherapy is commenced. So it's quite a lot for us to think about, never mind our patients. This is an example of the holistic needs assessment that I mentioned. So we encourage our patients to do this at the pre-chemo assessment. I tend to find a lot of our patients will have a number of physical concerns at diagnosis, and this is usually due to the impact that the lymphoma is having on them. I think often if we repeat this process again at the end of treatment, which we do, we find that the focus has shifted a little bit, and actually the physical concerns that they had, so the symptoms have gone away because we've treated the lymphoma successfully. But actually is what our patients might be experiencing at the end of treatment is that they've got more practical concerns, more emotional concerns actually. You know, a lot of our patients have been used to coming to see us every 2-3 weeks for chemotherapy, and then at the end of the treatment we're now saying, well, we only need to see you in clinic every 3 to 4 months, and eventually every 6 months. So this is something that we do along the way throughout the patient journey, which we feel is quite important. And although these are conversations that we think would flow easy, I think, you know, there are things on there like, you know, about sex and intimacy, and a patient might be quite worried about discussing that with us, but actually we find that if we give them this questionnaire, they can just tick that, and if they want to revisit it at a later date, or we might say, well, we'll give you a phone call about that. It might not be that we're in the best of environments to discuss this today, but we can ring you when it's a little bit more private. So we find this quite a powerful tool. So the logistics then of having chemotherapy, where I work, we provide day case chemotherapy. A lot of our lymphoma patients are treated as an outpatient. We do have an inpatient ward as well. So it very much depends on what chemo regimen we're giving. If this is a protocol that, the treatment takes many hours, many days, then patients might need to have an inpatient stay, but predominantly it's done as an outpatient. The number of the cycles depends on what chemotherapy we're giving, and again, the frequency also depends on the regimen. I often say to our patients when they're coming for the chemotherapy, make sure they bring things that are comfortable. They might be sat in a treatment chair for many hours, and although we have the unit set up very nice and it is comfortable, actually bring some of your own, your own blanket, your own pillow if you think that's useful. Bring an iPad, because actually it's quite boring just being sat there hooked up to treatment. A lot of patients say to me, well, how will I feel? I think, that first appointment, you've never had chemotherapy, so you don't know what to expect. I usually say to my patients that I would expect you to feel just the way you do now. You're not suddenly going to feel unwell. There is a chance, of course, that, these are drugs that you've never encountered before, and there is a chance sometimes of what we call infusion-related reactions. Often we know which drugs are the culprits and what tend to cause someone to feel unwell. And we do our best to stop that from happening with pre-meds such as steroids and antihistamines. But otherwise, I would expect, if the patient's not having any kind of a reaction, they should just feel as they normally do. They shouldn't really feel any different. Side effects tend to happen in the days or weeks after, and even months after treatment as well. Chemotherapy is given in various ways. It can be given intravenously. I would say that's the mainstay of our treatment. Some drugs are given subcutaneously, so just as an injection under the skin. We have some chemotherapies that are given by tablet as well, which means that the patient can self-medicate at home. Very much depends on what we're treating and what protocol that they're having. At the moment, on my day unit, we're not allowing visitors and relatives. I think that's been the fallout from COVID, really. We're very short on space on the day units, and it's getting busier and busier. So unless absolutely essential, unless somebody has specific caring needs that they need someone to be there, we are encouraging family members just to drop at the door, which again can be quite daunting. So what I usually do is allow family members to come to the pre-chemo assessment meeting with our nurse specialists, so they can actually see where their loved one is going to be having the treatment. But yeah, at the moment we've not really revised having visitors on the day unit, and I think we're still being super cautious. COVID is still out there, and we are still encouraging the wearing of masks on our day unit, even just to protect our patients. So side effects. Now, by no means are the side effects just restricted to this list. If ever I give out an information leaflet on R-CHOP, for example, there are about 17 pages of side effects, and that can be really, really overwhelming. So I would say that these are what I call the headline acts, sort of your main side effects. Now, again, at that pre-chemotherapy assessment appointment, I like to say to patients, it doesn't mean that you're going to get all of the side effects. I think from my experience and having given a lot of these chemotherapy drugs over the years, I can say which ones are more likely. And of course, that depends on what drug you're having. So, I always like to reassure my patients to say, you could read the side effect profile of paracetamol, an antibiotic, and actually there's a long list there, but that doesn't mean to say that you're going to get every single one. I think infection or the risk of sepsis is high for our patients, and I think, thinking about COVID, that's something that we've been on high alert for 3 years now. But actually, sort of shielding our patients is not a new concept to us in haematology. We've always encouraged our patients to be super cautious, around the risk of infection. Now, I get a lot of patients who say, well, shall I stay home? Shall I not go out? I think having chemotherapy can be quite an isolating time anyway. So I think a lot of this comes down to common sense. I think, we should be encouraging our patients to be as active as they can be to get out, but maybe that should be in an area that's not quite as crowded. I've got a lot of patients who live with small children, and of course they can't just, turf out family members, and children carry bugs. I tend to reassure my patients that actually any infections usually come from within themselves. If we think about bugs that live quite naturally in our mouths, in our guts, usually if you're going to pick up an infection, then usually it's our own bugs that seize that opportunity when the immune system is down. So again, a lot of education goes into telling our patients what to look out for, who to ring if they do suspect that they've got an infection, and getting prompt treatment for that to minimise the risk of sepsis. Bowel problems can be an issue with chemotherapy, and that could be from constipation, it could be diarrhea. But again, it's encouraging patients to report when it's a problem. So although we might expect that diarrhea can be a side effect, I actually would like to know if a patient is experiencing that, because I need to unpick, have they got a bug, rather than it being a side effect of the treatment. If they've got constipation, actually just educating patients that they can take a laxative, that's fine, and not maybe leaving it for 7 days, 10 days without alerting the health professionals that they've not been to the toilet, okay, because they're going to be feeling pretty miserable and uncomfortable if they've not been to the loo by then. So we do make sure that our patients have direct contact numbers for our day unit, and then out of hours at the weekend and bank holidays, we expect the patients to contact our ward for any advice. We also have really good links with our GPs as well, so that, if we need a GP to out of hours to see a patient. Peripheral neuropathy, we mentioned that quite a bit in Graham's talk actually, and chemotherapy unfortunately can cause nerve damage, and this is something that we're continually assessing for. I had a lady last week who had 2 cycles of R-CHOP chemotherapy, and she'd come to see me in my chemotherapy interim assessment clinic. So the point of that clinic is just to make sure that actually she is responding to treatment, but also that she's not developing too many toxicities. Now I could see that she was touching her fingertips a lot. And I did say, have you got any funny sensations there? And she described it as pins and needles, but she said it was actually painful and it was beginning to affect function. She struggled to do a zip on a coat. She told me that she couldn't undo a crisp packet the day before. So we do have grading tools for toxicities. And I graded that as a grade 3. So the higher the grade, we're going from 0 to 4 actually, then that's a problem. Okay, so I always encourage our patients to be as honest as they can to report any toxicities, because for her, we now need to tweak her treatment a little bit to minimise that future side effect, because we don't want to leave her with any permanent nerve damage. Skin changes can be common. A lot of patients complain of having dry skin. So again, I tend to educate about using things that are not highly perfumed, more natural products, things that we'd use on babies actually, just because your skin can become a little bit more sensitive. Encouraging high factor sun cream. You can burn so much more easily when you're on chemotherapy. So, there is really a lot to think about. Fatigue is probably one of the commonest side effect from chemotherapy, and this is something that can be long lasting, as Graham has said. Some of the other problems that we experience, for example, like nausea and vomiting, might just be short lived for a few days. But again, it's all about trying to prevent that happening in the first place, and making sure that patients are taking anti-sickness tablets rather than waiting until they feel sick. I encourage all of my patients just take the sickness tablets for a few days, and hopefully we're going to ward off that side effect. Chemo brain, my patients laugh when I call it this, but it is a recognised side effect. Feeling fogged. A lot of women complain of this when they're in the menopause as well. Actually, your thoughts, you just can't get the words out, you can't articulate. So encouraging things like brain teasers and word searches, just challenging your brain a little bit. Sore mouths can be a problem. Good oral hygiene is encouraged, soft toothbrush rather than a hard one. But again, letting your team know that if your mouth is sore, because actually if you can't eat or drink because your mouth's sore, then we need to know about that. So what we can do to try and minimise it with future cycles. So low blood counts, now we do know that the immune system can struggle, and that's as a consequence of the white blood cells dropping during chemotherapy. Often the red cells can drop, so our patients can become anemic. Platelets, which are the sticky cells in our blood to help us to clot, they can often drop during chemotherapy. So things to look out for there would be bruising, bleeding problems. So again, it's all about reporting back to the team. I always say to my patients, you know, if your chemotherapy is once every 3 weeks, if I don't hear from you within that 3 weeks, then I assume all is okay. I can only help and advise if I know that there's a problem. Fertility loss, I've already mentioned, but again, thinking, you know, some of our younger ladies, you know, we've had some young women who have actually tipped into an early menopause very early. So again, it's making sure that we have good links with our GPs and that they're educated to look out for these sort of late effects from treatment, if you like. So with the late effects, we do like to, you know, be as open and honest as we can with our patients at the start. We've already mentioned things like cardiacs or heart toxicity. But, you know, I always say to the patients that I'm treating that, you know, everything is risk and benefit, isn't it? So, you know, at the point where you're needing to have chemotherapy, then the biggest benefit is that we want to induce remission or potentially cure the lymphoma that we're treating. And we have to accept, unfortunately, that that may be as a consequence, you know, because of some late effects like heart toxicity in the future. So again, it's all about encouraging our patients to lead a healthy lifestyle in the future. You know, if they're smoking, actually, could they stop smoking? Maybe, you know, reducing alcohol consumption. So this is where to get the help and support. So a good starting point would often be your nurse specialist. I'm very lucky in my team that we have 2 excellent cancer support workers. There is support for our patients and the nurse specialists as well. There are 2 nurse clinicians in my team. We seem to be expanding year on year. Our day units, so, you know, our patients are given an emergency contact card. So it's got the day unit telephone number on there. It's got the ward out of hours. We've got Macmillan Information Centres. So I would really, really encourage you to see what's out there in your area if you're not sure who to contact, because the help will be out there if you need it. Thinking about things like counselling and complementary therapies. It's really important, you know, thinking, actually looking after your emotional well-being as well, and sort of welfare and benefit advice as well. You know, often if you're unable to work whilst having chemotherapy, as a lot of patients can't, then there might be things like Macmillan grants that you're entitled to, personal independence payments, attendance allowance. So really do reach out so that you can get some help and support from the right people. So after chemotherapy, this can often be a daunting time. You're waiting to have a scan, you're wanting to know the results. Once our patients have finished treatment and they've had the scan results, we do invite them back in for what we call an end of treatment summary appointment. So we sort of reflect on the treatment that they've had. We talk a little bit more about late effects and what to look out for. We discuss what the future management will be, how often they'll need to come back to the hospital. But as I said earlier, often we don't need to see patients that often. We're even looking at self-supported management within my team. And that would be putting the onus on the patient to trigger if there's a problem. So again, all of this can be very, very daunting. So this is a good time for us to look back at that holistic needs assessment and what support can we put in after the treatment is finished. Often patients will ask, when is the right time to go back to work? I think that's very individual. There's no right or wrong here, and often, you know, many of my patients, it might be a time that they need to reassess, you know, take an early retirement and things like that. But these are conversations that you can have with your clinical nurse specialist or your consultant when you come to clinic. Holidays, often everybody, you know, wants to look forward to a holiday, especially after COVID for the last few years. This can be very difficult when you're on chemotherapy and often not advised due to the risk of infection. But again, if you speak to your clinical nurse specialist, they might be able to offer advice on where to get adequate health insurance, travel insurance. You know, it's always nice to have something to look forward to at the end of treatment. So thank you for listening. It's been a little bit of a whistle stop. I could probably talk for hours about chemotherapy because there's so much to think about.
That's fantastic, Ruth. Thank you so much. There was so much amazing information in there. So I'm going to invite Graham to come back and join us and try and get through some of the amazing questions that have been given to us. Graham, I'm just going to start with you, if I may. You did touch on when to start chemotherapy, but we've had a couple of questions asking about how do you know when chemotherapy should start after being diagnosed?
Yeah, no, that's an excellent question. And the most important thing, again, goes to that question, why are we giving the chemotherapy? So if the aim is cure, and by that I do mean cure, get rid of it completely so it never comes back, and that's a possibility with Hodgkin and high-grade non-Hodgkin lymphoma, then really as soon as possible, because as the cancer spreads, as it sort of goes to different organs, the chance of cure does go down a bit. I mean, even very advanced lymphoma has a relatively high chance of cure, both Hodgkin and diffuse large B-cell lymphoma, for example. But so when cure is the aim, straight away would be my recommendation. When cure isn't the aim, then actually it's really we're treating complications of the lymphoma. So let's say somebody has a low-grade B-cell non-Hodgkin lymphoma, follicular lymphoma. We would often advise simply observation. Sometimes we call it watch and wait, sometimes active surveillance. And we do that because when patients are really well, there's no real benefit of treating the lymphoma. But if the lymphoma actually starts causing problems, so an unsightly, uncomfortable lump, or it starts making people anemic, or they start getting weight loss because of the lymphoma, then absolutely we should treat it because it's interfering with their quality of life. And there are various sort of published criteria, if you like, that we loosely follow, I would say, in the haematology clinics of when to start treating a patient. But it's more when their quality of life is impaired. That's the main reason.
Fabulous, thank you. That's really clear. And just staying with you for a moment, Graham, somebody has asked or said that they hear that chemotherapy becomes less effective the more you have. And I just wondered whether you had anything to say to that one.
Yeah, no, that's interesting. So I'd say, how do I answer that one? Yeah, yes and no, I think is probably the way I'd answer it. We often wouldn't use the same chemotherapy twice. So there are some instances where we might, but on the whole, we wouldn't. So let's take rituximab bendamustine. If you have that for treatment of follicular lymphoma and you relapse, let's say 3 years later, well, that's not a great remission. I wouldn't use it again because the next remission is likely to be even shorter because of this development of resistance that I talked about. You may be developing resistance. However, if you switch chemotherapies and use a completely different regime that works in a different way, such as R-CHOP, you might actually get a much longer remission second time. So I think it's, using the same drugs again, completely agree, but switching to different drugs in some circumstances can restore the sort of effectiveness of chemo. But sometimes, there are some patients where no matter what chemo we use, they have developed resistance to chemo. Generally can happen, and chemotherapy doesn't always help in that situation.
Fabulous, thank you so much. And Ruth, you touched on fertility preservation, and we've had some questions on that. From your talk, what would be your top tips for somebody that was wanting to discuss fertility preservation, maybe a very young person perhaps?
Absolutely. I think, don't be afraid to ask the question. Hopefully the team will bring that up anyway. But if they don't, then make it clear that that's a concern for you. I think don't be embarrassed is the thing. We've heard it all, we've seen it all, and I know these conversations can be very difficult. I've had younger patients who are often in the room with mum and dad, and they don't want to bring that up. Sometimes I'll just throw mum and dad out and just say, right, should we have a little chat on our own? So I think, as health professionals, we're very good at having these conversations anyway, but sometimes we can get sidetracked with other issues. So if it doesn't come up, you absolutely must bring that up because it's really important, and there is usually a solution out there.
That's great, thank you. We've had a couple of questions about side effects, Ruth, and whether or not they kind of accumulate over the weeks that you're having treatment, or whether you do get to a stage where you're feeling much better and then you have your next treatment.
Yeah, I think it's variable from all of the different side effects that are out there. So things like the peripheral neuropathy, the tingly fingers and toes, then that sometimes does actually accumulate, and we don't want it to get that bad that patients are losing function. Things like fatigue, that can also accumulate. But I often say to my patients that they do probably follow a bit of a pattern. You know, if they're having a chemotherapy that's maybe every 2 or every 3 weeks, they'll know what tends to be the good days and the bad days. You know, it might be that if they were experiencing nausea, then that's going to be in the immediate first few days after treatment. I wouldn't expect our patients to be sick 2-3 weeks after the chemotherapy, and that could actually indicate that they've got a bug of some description. So it is variable from side effect to side effect. Some sort of straight after treatment, others, yes, can accumulate.
Graham, you're nodding there. Did you have anything you wanted to add in?
No, I absolutely agree with Ruth. I mean, there are, you know, infection is quite an interesting one, because infection is, medically speaking, we worry about that probably the most. And we often advise patients, you know, take your temperature regularly, ring us if it goes over a certain number. And that's a really, really important advice for any point in chemo. But actually, the riskiest cycle for chemo is quite well described now, is the first cycle. So whereas some complications absolutely build over time, others, the first cycle is potentially the most risky. But I would emphasize for anyone listening, temperature at any point during chemo, please do get in touch.
Right, thank you. That's a great top tip there. And just thinking about the later side effects. The later side effects that you chat with patients about, and I'm going to pick fatigue and pain because that's been brought up by somebody listening to the webinar live today. Do you expect some of those late side effects to be for life, or is there a point where that person should be exploring those suspected side effects with their GP, for instance, if they're continuous?
I would say, although we do expect these complications can be long lasting, absolutely, I think, you know, if they're lasting many months, then it's often worth having a conversation with your GP. I think it's very easy to blame the chemotherapy and lymphoma for everything. You know, once you've had a diagnosis and you've had treatment, yes, it probably is going to be your first thought, but actually, could this be because of something else? You know, you know, is the patient on medications that have not been reviewed for a long time that are just slowing them down? Have they got new problems? Do they need the thyroid checking? There could be many reasons that someone is fatigued. But, you know, again, I do find that this often can be long lasting.
Graham, have you got any observations from your practice on that?
Yeah, no, again, echo what Ruth says, absolutely. I mean, fatigue, you know, fatigue is a really difficult one, and what we're acutely aware of is that we don't have much really of a solution. I mean, there's certain lifestyle advice, you know, a graduated exercise program sometimes can be helpful. Sometimes fatigue can actually be reflective of a mental health issue. You know, it's actually quite common for people to struggle with anxiety and even depression when chemo stops, you know, which is a bit odd. You might think, you know, that most anxiety depression happens at diagnosis, which absolutely can do. But while people are on chemo, often, you know, they're seeing doctors, nurses very regularly. It can be quite positive when lumps shrink away. But then suddenly when we say, oh, we'll see you in 4 months, get on with your life. I mean, we don't quite say it like that, but it can feel like that, I think, sometimes. People can really sink into, have difficult mental health issues, and that can manifest fatigue. So fatigue is a hard one. Neuropathy, the other thing to say about that is it can, you know, sometimes you can get benefit up to 2 years later, you know, so I do often say to patients at sort of 6 months, still give it time. It may not get completely better, but it can take sometimes up to a couple of years.
Okay.
Sort of max.
Oh, right, that's really interesting. Thank you. This is a fantastic question. But does chemotherapy ever completely leave your body, or do you always have some after you've had treatment?
Yeah, it is a good question. I mean, I would say that, well, often people say to me, how long does chemo hang around for? And my usual answer is not very long. You know, so when drugs are first tested, they often have what's called a pharmacokinetic evaluation. It means how quickly does the drug get out of the body? You know, how quickly do the kidneys and liver get rid of it? And normally it's pretty quick. You know, normally it's a matter of hours, if not days. So most chemo does get out of the body pretty quickly, but, and it is an important caveat, its effects can be really quite long lasting. So, you know, even though the chemo's out after day 2, you know, you can still be feeling it after 3 months, 4 months. The exception to that, there are drugs like, for example, rituximab, which is an antibody that's cleared much more slowly, so that can stay in the body for quite some months. But yeah, we should be clearing it completely. I mean, another just brief thing to mention, Ruth mentioned brain fog, which, you know, absolutely, you see it all the time, chemo brain. but the chemo that's often used doesn't actually get into the brain. So it's not as if, it's not brain damage, it's not the chemo getting into the brain, it's more complicated effects on the body, which then affect the brain. You know, so it really is very complicated, some of these effects.
Thank you for making that clear, Graham, because I think, yes, chemo brain, I know it's definitely a thing, but it's good to hear that's not because the drugs are actually affecting your brain directly. It's just as a side effect of everything else that's going on for you when you're on chemotherapy. We're going to divert just for the last couple of questions, possibly more for you, Graham, if you don't mind. But we've had some questions about should or would the benefits of having radiotherapy after chemotherapy be of benefit? Should people be having radiotherapy after chemotherapy? And the other one, if I might add it on, is about immunotherapy and when should that be considered?
Okay, I'll try to be brief. There's a good few essay questions there. So the benefits of chemotherapy is it affects the whole body. So no matter where the lymphoma is, apart from maybe the brain, at least for some chemos, no matter where the lymphoma is, the chemo gets there. Radiotherapy is very good for localized areas. So there are some lymphomas like follicular lymphoma where if it's only one area, actually radiotherapy alone can be a really good treatment, even a cure potentially in that setting. So localized areas. And sometimes if people have got high-grade lymphoma, for example, that's in several areas, but one area is very bulky, and you treat it, and maybe there's a little bit left on a PET scan, actually radiotherapy to that single area can be very effective at reducing the chance of relapse, i.e. increasing cure. So in some patients, radiotherapy can be a very good modality. One thing we worry a bit about, particularly in younger patients, is the late effects. So we've been talking about late effects. The radiotherapy, for example, in somebody with Hodgkin lymphoma, who are often younger patients, if we give it to the chest in a young woman, then that often involves breast tissue, and that might increase the risk of breast cancer later in life. Now, as Ruth said, everything's risk and benefit. The benefit of that radiotherapy may outweigh that risk, but it may not. And it's often the patient that can actually guide us as what they accept as the right risk-benefit sort of ratio. So, yeah, radiotherapy certainly has some issues which need to be carefully weighed up.
And I think these are things that we do discuss before we start treatment. I know we'll often have a clinical oncologist in our MDT, you know, so these are things that we do think about before we meet a patient in clinic when we're discussing treatment plans.
And then immunotherapy, just to touch on that, because people often say to me, what about immunotherapy? It's a bit like saying, what about chemotherapy? There's loads of different types of immunotherapy. Do people mean CAR T? Do they mean these things called PD-1 inhibitors? So what I normally respond is that some immunotherapy just doesn't work in lymphoma. So, you know, immunotherapy as a whole is not necessarily the right thing to have. But there are other specific types of immunotherapy that may work very well in certain types of lymphoma. So CAR T and multiply relapsed high-grade non-Hodgkin lymphoma, very good choice. Whereas, you know, PD-1 inhibitors, which is a type of immunotherapy drug, brilliant in Hodgkin, terrible in follicular lymphoma. So it really depends on the type of lymphoma, the stage in the treatment pathway you are, and the type of immunotherapy that you're talking about.
That's fabulous, thank you. Sadly, I'm going to have to bring the webinar to an end in just a moment, but thank you both. That was such an amazing webinar, so much information and brilliantly put across. So thank you both very, very much. If you're viewing this webinar and your particular question hasn't been answered during the webinar, please do get in touch with the Lymphoma Action Helpline team. They're there and available Monday to Friday, 10 till 3. So please do give them a call, or perhaps look on our website, because there's a massive amount of information, not only about lymphoma, but also about chemotherapy as well. But for now, I'd like to say thanks again to Graham and Ruth. Thanks to all of you for joining us. Wish you a great day and see you again soon. Bye for now.
Pleasure, thank you, bye.